Okay, well, I'm happy to go ahead and get things started. Thanks again, everyone, for joining us. My name is Todd Jensen. I'm a faculty member in the School of Social Work at the University of North Carolina at Chapel Hill. I'm also the leader of the Family Measurement Node for the Life Course Intervention Research Network. We're excited to be continuing this webinar series. We're really just trying to foreground the role of families in supporting, exerting influence on the healthy development of children across the life course. And I'm delighted to be able to introduce two speakers who are going to be sharing some really fascinating work with us. And I'm so glad to see also that we're recording these webinars, so they are accessible for viewing following our time together here. So they can, a link to this recording will be made available. It can be shared with colleagues and networks. So please keep that in mind as well. But I'll go ahead and introduce our wonderful speakers. So first we have Dr. Mark Feinberg, who is a research professor at Penn State, who has made contributions to theory and research in areas such as co-parenting and sibling relationships, the epidemiology of adolescent behavior problems, transactions between family relationships and biological systems, and the efficacy of community prevention initiatives. Dr. Feinberg developed the evidence-based Family Foundations program, recognized by Blueprints as a model program and AMCHP as a best practice. He is founding director of ICOPAR, an international organization devoted to catalyzing advances in research and policy promoting positive parenting. I'm also very pleased to introduce Dr. Norma Perez-Brena, who is an associate professor of family studies and human development in the Norton School of Ecology at the University of Arizona. Her primary interests lie in understanding the combination of social, cultural, and personal characteristics that support Latinx adolescents and their families during key developmental and family transitions. Dr. Perez-Brena has experience in conducting quantitative and qualitative longitudinal family research. She also has nearly 10 years of applied research experience serving as director of evaluation for a large Southwest nonprofit organization and as director of a co-parenting relationship and life skills education program serving adolescent parents. So it is my pleasure to turn things over to our wonderful speakers.
Great. Thank you. And I'm going to share screen. Share these slides. Just a minor modification. The ICOPAR organization, International Co-Parenting Policy and Research, it's focused on promoting positive co-parenting around the world. And so I think it's the first organization dedicated to that. In any case, we want to talk about the life course health development in families, a model that we developed and published and related to co-parenting. And I'll talk first and give a little bit of a foundation and then describe the original Family Foundations program a bit, and then hand it off to Norma, who will be taking it in a probably more interesting direction and describing some of her work and further articulation of the theory. So this is the basic conceptual model that we published. We were trying to figure out how to relate families to health, big topic. And I found it very useful when approaching something like this. What's helpful is to provide a very general framework that people can use to organize research, to organize intervention, to guide intervention, development, and so forth. So it's a very, very broad kind of model. As you see, we have 4 constructs in the box of family functioning that all interrelate and are somewhat overlapping in ways. And then we believe that health, family members' health, influences these family dynamics, and then these family dynamics then go on and influence family members' health. So those four those four domains inside the family box. The first one is just family structure, which we use to refer to how the family is composed, who are the members of the family, and what are their roles and responsibilities. And as you can imagine, I mean, as you know, families will vary very widely in terms of composition, roles, and responsibilities. And then the second domain are family processes that we think about as ongoing strategies that families use. So we think about communication, decision-making. Of course, you can't kind of see these apart from the concrete behaviors that family members enact. But we try to differentiate behaviors from processes, as processes are patterns of behavior, and they tend to serve a function. And so we just think it's heuristically, conceptually useful to pull those apart. Cognitions are referred to how family members think and feel, and in terms of health, we think and feel and their values and priorities. And in terms of health, we think that what's critical, among the things that are critical, are their perceptions of themselves and others, their health knowledge and literacy, and as I said, their values, goals, and priorities. And then finally, behaviors. And then in that bucket, we distinguish between lifestyle behaviors, nutrition, exercise, sleep, etc., and then specific preventive health behaviors, and promotive health behaviors. Could be taking supplements, or I guess, yeah. And then help seeking, actually seeking, whether it's formal medical care or informal health support. And then, as you can see, this little basic in our model, this family box is kind of extends over time. So health influences families, influences health, influences families again at the next time point. And it's, of course, a continuous process. So now, having kind of laid that out, quickly, I want to just talk about co-parenting and where did the idea of co-parenting come from. It came from the divorce literature, trying to understand why some kids were more affected by divorce and others weren't. And people looked at how parents co-parented after divorce. And then researchers started looking at that relationship between parents before divorce. But before the work on co-parenting, there have been many decades of work on couple conflict, and it's been very clear for many decades how couple conflict undermines children's well-being in many areas, as depicted here on the slide. And the idea of co-parenting is distinguished from a couple relationship, and is simply defined as the ways that parents work together in their roles as parents, their cooperative, mutually supportive relationship focused on raising children. Of course, it doesn't have to be the two biological parents. It could be grandparents, adoptive parents. It could be a support person. It could be a new partner. It could be more than two people who are, the key is that they are responsible for rearing the child. And then the question is, to what degree do they collaborate and cooperate or not? When I came to this work, I synthesized the existing literature and decided that I saw four main domains at that point that comprise the co-parenting relationship, the dimensions. So the first was child rearing agreement, just simply do parents agree about child rearing values and how to raise a child. And that doesn't have anything to do with how they handle disagreements, but just the extent of agreement. And then second, the division of labor, how they negotiate and share the work of parenting. Third is the support and undermining of each other in their parenting role, which could mean undermining could be a direct attack. It could be rolling one's eyes. It could be saying something to the child that undermines the other parent's authority or relationship. And then finally, joint family management is how do the parents together kind of run the family? How do they set routines and set standards of how family members behave with each other? How do they interact together when all the family members are present? Does one withdraw, the other one takes the lead in playing or interacting with the children? The research has shown, just like couple conflict, that co-parenting has strong relations with many aspects of children's development and adjustment throughout childhood, from infancy through adolescence. And there are probably more factors I could add to this slide at this point. So what I believe is that the reason that co-parenting is a linchpin of family functioning, one reason is that it's the foundation of a parent's sense of worth and security and competence. There's nothing more important to a parent than whether they're a good parent or not. We will often give up our lives for our children if that's required. So there's nothing more important than taking care of our child. And one of the worst insults is to tell somebody that they're a bad parent. And since that is such a co-parenting relationships are so core or critical for a parent's sense of worth, that it affects parents' adjustment, parental stress, depression, anxiety, self-efficacy, and that parent adjustment, if you feel better, if you're less depressed, less anxious, and less and more confident, you're naturally going to be providing more sensitive, warmer, less harsh parenting to your child, and your child will benefit. So that's a basic conceptual model. And then with this, I developed the idea of an intervention that could help parents get on the same page during pregnancy before they have a child, not wait until afterwards and they're fighting and arguing to try to fix things. And some of the reasons to focus on co-parenting as an intervention target is that, as I said, it's very generalizable to all kinds of families, all kinds of family structures. It's a more precise target than the overall couple relationship. It's smaller. It has a stronger impact on parents' well-being, parenting quality, and child outcomes than the overall couple relationship. And even though this is sort of a gendered, stereotyped image, and I need to find another one, co-parenting support can be a buffer and protect and be a shield to protect against other risk factors. So if a parent is depressed, but they have good support from their partner, their parenting quality remains fairly similar, or can remain fairly similar. And you don't see the decrements in parenting quality that you do when somebody is depressed and they have a poor co-parenting relationship. And that's true also, I believe, for financial strain and other external risk factors. So thinking about the transition to parenthood, actually call it a crash into parenthood, you can see on this slide, is an important transition point in many adults' life. And it's stressful, and there's less romance, less affection. There's more conflict between partners after birth of a first child. So it's an excellent time for intervening and in a preventive way. The original Family Foundations program was a universal group group format for expectant parents, delivered through childbirth education departments at local hospitals, and was a series of, first it was 4, and then the second version was 5 prenatal classes and 4 postnatal classes, led by a pair of group leaders. And the main message in the program is the importance of working together as a team, and in the first place, just educating folks about, yes, of course you want to be a good parent, but one of the best things you can do for your child is to be a good co-parent. And to help people realize that, since that's, it's motivational, it's because people are so concerned about their child and their child's well-being. Once they understand how important the co-parenting relationship is, then they're motivated to put work and effort into enhancing that and improving it. So the targets for change in the program, we break into 3, and we use this breakdown in the program: feelings, thoughts, communication. We talk about that with the couples, and that feelings, thoughts, communication, FTC, also stands for first the child. So think about your child. If you put your child first, then you have to take care of yourself, and you have to take care of your co-parenting relationship. So feelings, we play videos of real couples, families, and they see, and through some of our education, didactic education in the program, we try to prepare them for the stresses of early parenthood, which most people, including myself, weren't aware of. We just think it's going to be great. We also do a whole lot around feelings and what are your feelings? How do you feel things? You're going to be your child's teacher. And then that allows us to help people identify feelings, and identify when they're angry, and identify what they need to do. One of those things is think about their expectations for their partner, and to develop some positive self-talk to counter negative thoughts that are prompting those difficult, angry feelings. And then finally, we teach and facilitate practice of some just typical, simple communication, problem-solving skills. So in terms of the life course health development model, we're talking about, for example, behaviors. So here we are definitely sharing some new behaviors for them to try on. We definitely focus somewhat on, or to some degree, on cognitions and attributions of their partner, and then processes in terms of, for example, division of labor. And so applying their communication skills and problem solving skills to how they divide up the workload, and how they manage situations where they're in conflict and become self-aware and take a time out or do other things to manage those situations, getting at communication processes. So I'm going to quickly just review some of the findings from here, the first two trials of the universal version of family foundations. This is FF1 is the first trial, and FF2 is the second trial. And these are outcomes collected 6 months, 1 year, and 3 years after birth. And just to show you the pattern of significant findings across both self-report and, where appropriate, videotaped observational methods, we found significant improvements in the, if you remember the elements of that logic model, in co-parenting, in parent adjustment, in parenting quality, and then also in children's at this age during infancy in their self-regulation. We found effects that extended over longer term for children. So, for example, at 3 years, we found children in families randomized to family foundations showed better social competence. Boys showed better or better mental health, fewer internalizing and fewer externalizing problems. At 7 years, we found boys and girls showed fewer internalizing problems. Boys still showed fewer disruptive problems. And then among those families at moderate risk, so in a videotaped observation during pregnancy, the parents are displaying some higher levels of tension. They weren't yelling and screaming at each other because they're being videotaped and they're behaving well. But those who are showing higher levels of tension in those discussions, their children, compared to the similar control children, all of them, boys and girls, showed better internalizing, externalizing, and school adjustment by teacher report. All of those findings were by teacher report. So in the second trial, that was from the first trial. In the second trial, we recently published a paper from data from parent report at the beginning of the pandemic. So during the acute shutdown period, and the children were about 10 years old at that age. And you can see a quote here. But we found, compared to control families, at that point, I should rephrase this as not just social distancing, but COVID-related health protective behaviors, that parents were reporting that the mothers and children were making more effort in implementing those behaviors, and there's less conflict between parents and children about those behaviors, which I think is very important, because if there's less conflict and less stress, then people are going to be able to sustain those health protective behaviors over a longer period of time, which I think is a key idea that I don't think we pay enough attention to, is how family relationships and family dynamics contribute to important, socially important health behaviors. Anyway, parents also reported that they were displaying less harsh parenting and more warmth than control parents, and in the families where they had other children afterwards, because these were first-time parents in the trial, that their siblings had better relationships, and their children and the target children showed fewer disruptive behaviors. here's our conceptual model again with some of the outcomes that we found and were replicated. We also found surprising findings, things we didn't predict. I mean, at the very beginning when I proposed this as an R21 project, it's very short term. I was hoping we would, you never know, was hoping we would have an impact on co-parenting, and really hoping that that would then have a downstream effect that we could detect on parents' adjustment and depression. Never thought we would actually then see the next stage of impact on parenting quality and then even on child outcomes. So really the expectations for this work at the beginning were pretty low, and just been surprised over and over along the way. So research has come out since we started this that had shown the relationship between maternal stress and anxiety and birth outcomes. So I said, let's take a look and see if we maybe had an impact on birth outcomes. We found this was moderated. We did, but we found it was moderated in the first trial by prenatal maternal levels of cortisol, and in the second trial by maternal self-report of stress, depression, anxiety. These are fairly small trials. They're not high-risk families, so it's hard to see impacts on birth outcomes because the negative impacts are constant. The negative birth outcomes are concentrated amongst the higher risk families. So it makes sense that in these trials we would find impacts moderated by these related factors, one biological, the other mental health. So we found in both cases higher birth weight, in one case less premature birth, and shorter hospital stays in both cases for the infant, one for the mother. We also found impacts on family violence, both between the couple and parenting aggression. And one of the things that amazed me was that we found impact on harsh parenting, physically harsh parenting to children at 12 months after birth, which says there's enough harsh parenting of infants that we could detect a change. And over the years, I've come to realize that physical aggression in families is much more common than we think, than we generally think it. And 30–40% of families are, I would say, are in the physically aggressive, show physical aggression when children are young, at least 30 or 40%. Physical health, we also found surprising. We found that mothers retain less weight 12 months after birth. 1 kilogram doesn't sound a lot, 2 pounds, but over a population that is a substantial impact. And then we also found maternal, we found reductions in systemic inflammation among both parents for IL-6 and mothers for CRP. And there's also a note that IL-6 was moderated by prenatal levels of couple conflict. So I want to give Norma a good amount of time. So I've been running through this really quickly. But here is a sort of a elaborated conceptual model, because now we know that we have an impact on parent health, and maybe it's because I think it's because we have an impact on parents' mental health and stress and so forth. And that then perhaps is why we saw better birth outcomes, both because of better mental health and better physical health. And those better birth outcomes then may contribute to better child well-being as well. I think I can stop here and give Norma the floor or screen.
Great. Thank you, Mark. That was great. So I'm going to go ahead and share my screen. And there we go. So hopefully, does everybody see just the PowerPoint, not the notes? Okay, great. All right, so I'm going to build off of what Mark has shared and talk a little bit about how we're also thinking about incorporating and acknowledging sociocultural factors into family-focused programming, in particular into the co-parenting intervention family foundations. So what I'm going to do, and I'll try to do in about 20 minutes or so, hopefully a little bit shorter than that, so we can have time for questions, is I'm going to describe a working model that we in the family health node are working on to better integrate the idea of social determinants of health and intersectional perspectives into the FHD model that Mark had mentioned at the beginning of his presentation. And then I'll talk about some recommendations for integrating more equity and inclusion into family-focused programs. And then I'll describe a current project that I'm overseeing that's integrating some of these several elements to support Latinx adolescent parents, in particular in the form of the adaptation of family foundations. And I'll talk about some of the outcomes that are related to that. So, as Mark mentioned, last year we published a conceptual model thinking about how families kind of leverage structure, processes, behaviors, cognitions, and values to help promote both family health and individual health. And the idea is that through these different processes, families are able to develop kind of a emotionally secure space for individuals to feel a sense of safety and that will promote health, as well as through these mechanisms, families can leverage and activate resources to help protect and promote health. Now, within this model, if you noticed that there's this big gray circle that says social determinants of health, and this is usually how we see external macro context depicted in a lot of our figures, both from when we think about Bronfenbrenner and all of these other theoretical models. But it's important for us to really understand, what are these mechanisms? How is it that these social determinants of health kind of impact families and get into the family system? So within the family health node, we've been talking through, and actually probably Mark's like, wow, this figure, I've never seen it before, but we've been talking through a lot of these ideas, and we've been putting together some of these proposals of thinking about how these mechanisms happen. And so this is kind of a visual representation of how we think this happens. And so what we argue is that social determinants of health, such as like laws, policies, norms, and values, including racisms and other isms, impact the family through creating promotive or inhibiting contexts that the families have to interact with that might create stressors or help activate or give access to health resources. And this is happening in a couple of different ways, both through structural mechanisms via like policies and laws that decide where resources are allocated to whom and under what regions, through the bureaucratization of systems, that is, for example, the development of enrollment and eligibility processes, again, deciding who can receive services, who can't, who is allowed into certain programming and whatnot, via hegemonic mechanisms, via, like, for example, the discourse about different groups, developing stereotypes about different groups or ideas of what is or is not normative, which that might impact how policies are created. And then through interrelational mechanisms, for example, interpersonal discrimination or supportive interpersonal processes, for example. So this all creates kind of a promotive or inhibiting environment in neighborhoods, schools, and other contexts that then both impact individual and family health, but also enter into the family system, who then has to adapt to this. And of course, families are, not passive in this experience, but develop various resiliency tools or adaptive cultural mechanisms that help kind of adjust to or adapt to and build resistance against prohibitive systems. So this might be in the form of development of cultural values and meaning making, for example, the development of ethnic racial affirming ethnic racial identities and processes that can be protective in the face of marginalization, and culturally and contextually specific family processes. And so all of this allows us to kind of think about different places where we might develop interventions to work in collaboration with our families to either develop protective mechanisms or to advocate for change with our families. So how do we actually do that, though? Now that we, kind of depict this model, how do we integrate social determinants of health and cultural responsive ideas into family-focused programming? And so here I'll just provide one potential recommendation. Something to keep in mind is some recommendations that have been provided by the National Academy of Science, Engineering, and Medicine, or NASEM. And they advocate for us to think about awareness, adjustment, assistance and alignment, and advocacy. And so by that, what they mean is that we need to be aware of the contextual factors that families are dealing with and the cultural and individual resources that they have, so that we know how to then adjust our programming to be relevant and responsive to their needs and to their goals. We need to then with regards to assistance and alignment, the idea is that we want to identify family strengths and help families leverage those already pre-existing strengths and goals and work in alignment with them. That is, work in collaboration with them, as opposed to thinking about things being done to our families, but really working in collaboration with our families to impact change and also to advocate for change at upstream levels of the environment. So really advocating for systemic changes, not just providing programming. So this allows us to really think about how we can promote and support families at multiple levels. Now, again, these are good recommendations, but there's so many ways that you can do this. So what I'm going to do next is just provide an example of how we've been doing this in a program that specifically works with adolescent parents. And the way that we've done it is through engaging in some cultural adaptation processes, in particular to adapt the Family Foundations program to be specifically relevant for Latinx adolescent parents in a school context. So a little bit about adolescent parents. Although the rates have been significantly decreasing in the US over the past 20 years, the US is still reports some of the highest rates of adolescent parenthood across the globe. And for the US in particular, this is related to adolescents experiencing significant amounts of stigma and interacting with systems that aren't necessarily created for them, because they're created with the context of thinking about adult parents and what adult parents have to do. So to kind of bring an example, for example, is that for adolescent parents, because they're both underage, but also parents, in the context of the state that I was working in, which was Texas at this time, adolescents could make, for example, decisions about their child's cancer treatment should they experience some kind of health condition, but they cannot make a decision about their own personal contraception without a parental consent. So there are a lot of things that adolescent parents are having to navigate that have to do with the intersection of their age or them being an adolescent, as well as being parents. And what that relates to with co-parenting is that co-parenting can be very complex. Because they're adolescents, they're often living within their own family. So they're often co-parenting in multi-generational, in multi-generational households, and they're engaging in multi-generational co-parenting. They're also co-parenting often within and outside of the home, as often the other biological parent of this child is living with their own parents, for example. So there's a lot of navigation of multiple family systems. And what we see is that there's also a high rate of co-parenting after breakup. So 58% of our adolescent parents are often not in a relationship still within the first year of becoming parents. So there are a lot of complexities for them to manage, but we know, as Mark has shared, that co-parenting can be an important mechanism through which parents develop a sense of self-efficacy and support and promotion of mental health. So this is something that we wanted to target in support of our adolescent parents. And of course, when looking at Latinx adolescent parents, are not only at experiencing this transition into parenthood at the intersection of adolescence and the transition into parenthood, but also they're at the intersection of race, ethnicity, adolescence, and parenthood. So with that in mind, we wanted to bring a co-parenting intervention to the adolescents that I serve. And what we've noted is that for the most part, most co-parenting interventions has really focused on adults and primarily intact families. And so we wanted to see how we could promote and support our adolescent parents in co-parenting. And at this point, in 2015, I reached out to Mark to see if he would be interested in adapting the intervention for our adolescent parents. And I was very happy to hear that he agreed. And to be a part of the process of engaging in a cultural adaptation. And so within our team, we engaged in a cultural adaptation framework, which involves 3 steps. First, you begin collaboration with key stakeholders and you gather feedback from multiple stakeholders to decide if an adaptation is actually needed, or if that program is needed at all, or if the program is good and good to be implemented as is, for example. If an adaptation is needed, then you start engaging in the process of adapting that program with feedback from stakeholders, and then you pilot that adaptation and integrate final feedback to then fully implement. So those are kind of the basic steps, but I'll talk through a little bit more of those steps. And so in terms of phase 1, what we did is we engaged multiple stakeholders. We completed several focus groups with adolescents, or I should say adolescent parents, with their own parents, who I'll call the grandparents, and with school staff who serve adolescent parents. And we did this so that we could get feedback from multiple stakeholders from multiple perspectives to understand the complex relationship that adolescent parents were engaging in. We also reviewed the literature just to make sure that we didn't miss anything. And again, we reviewed the information to decide next steps. So with regards to what we found in these various focus groups that we engaged in the interest of time, I'll run through these pretty quickly, but what I'll highlight is that oftentimes when talking to our adolescent parents and the grandparents and the school staff, they talked about how co-parenting happened in diverse co-parenting structures. It wasn't happening as dyads. Instead, what we found is that more often than not, adolescent parents were engaging in co-parenting with triads or quads. That is, for example, they were co-parenting where it was the adolescent mom, the adolescent dad, and a grandparent were the primary co-parents who were engaging in supporting the child or supporting the adolescent mom through the transition into parenthood, for example. They were also engaging in a lot of multi-generational co-parenting, but they were engaging in co-parenting with other family members and other people that we didn't consider, for example, with the other parent, of course, with the grandparent, with in-laws. They were co-parenting with their siblings, so siblings were becoming a very strong source of support for them, or co-parenting with other romantic partners or friends who were part of kind of providing support. In terms of co-parenting support, our all 3 focus groups talked about how co-parenting supports came in the way of childcare, supporting childcare tasks, providing emotional support, instrumental support, as well as this theme of teaching responsibility. And I have it highlighted and kind of slashed responsibility self-care, because when adults talked about this theme, they talked about how adolescents were very selfish, and they didn't want to take on parenting responsibilities. So the adults had to impose rules on them to teach them responsibilities. Whereas the adolescents often talked about this idea that, sometimes when they became parents, sometimes they just wanted to take a moment to take a walk to calm down and engage in self-care, but they weren't allowed to do that. So this is one place where, thinking about the themes that we talked a little bit earlier, this is one place where perceptions about who adolescents are might impact how adults create structures for what adolescent parents can or cannot do, and impacts their parenting. Some other things to note were, across all groups, they talked about, the complexities of collaborating across multiple households with multiple co-parents, especially when there were engaging in families that had, never met each other until the child became a parent, for example, or multiracial families where there might be diverse kind of cultural values and so on. They also talked about this context of also experiencing some challenges with control and gatekeeping. And again, I have this one started because this one was experienced differently by adults than adolescents, in the sense that adults would talk about how they would provide advice to youth, but adolescent parents would discuss how when their own parents gave them advice, because they were living under their home, they felt that that was more of a demand and an expectation. So they didn't feel like they had as much power in their parenting goals, as well as grandparents in particular discussed how they often set rules for the house in terms of like who could come in and who could come into the house, or like curfews. And that was their way of imposing rules in their own home. But for the adolescent parents, they talked about how that impacted the way that they wanted to have the other parent involved in the child's life. So they, in particular, this related to gatekeeping of the adolescent father and how much he can be involved in the child's life, especially early on. And there were also challenges that they talked about with regards to cultural and generational discrepancies in parenting style. So all of this to say, there were some things that we needed to consider when thinking about the Family Foundations curriculum, things that we wanted to integrate. So based off of this feedback, we went ahead and decided to adapt. We also reviewed the literature on Latinx families, kind of identifying some values that might be more prevalent or issues that might be more prevalent within families that we needed to consider. And we looked at literature that talked about kind of best practices for working with adolescent parents. And two things I'll note about that is that it's recommended that long-term school-based programs be used. It gives them more time to practice skills. And by implementing in the school, it makes it easier for students to participate in the programming because they don't have to, because they're already overloaded with responsibilities with attending school, working, and parenting. So to add one more thing for them to do might prevent them from attending the program. So all of this to say, this informed the way that we thought about the program. And what we did is we engaged in both surface level adaptations, which is kind of changing certain language or examples and metaphors to make them more relevant to our adolescent parents. So for example, we talk about team parenting as opposed to co-parenting to think about the larger collaborative caregiving team. Surface adaptations might also be like something like delivery method in terms of implementing in community versus in the schools. Deep adaptations are something focused more on like focusing on relevant issues and aligning values and motivations. So in terms of surface adaptations, what we did is we adapted the Family Foundations curriculum so that it could be implemented in the schools. We made it 10 one-hour sessions. Because our students were being identified as pregnant or parenting, and we didn't have as much control about who could participate in terms of like only serving parents who were in their third trimester, we adapted the program to be relevant for both pregnant and parenting teens. So that means our examples included both. And we noted that couples weren't required to participate in our program. So instead, we made it so that individuals could participate by themselves, or they can invite someone who they consider to be part of their parenting team to be a source of support in participating in the program. which meant that our examples and our activities had to be more inclusive of diverse co-parenting structures. In terms of deep adaptations, some of the things that we did was we talked more within this curriculum about diverse co-parenting structures. And that is kind of embedded in the different examples and activities that they do. We talk about managing breakups and co-parenting, and we discuss multi-generational co-parenting. We also kind of embedded ideas about the importance of co-parenting for the child's well-being, and really talking about the idea of family obligation and the sense of doing things for the family in order to kind of highlight why co-parenting would be important to consider, as opposed to thinking about other activities. With regards to self-care, this is someplace where we provided some language and with the adolescents collaboration around how they could advocate for self-care for themselves within the family, and how that specifically helps them be better parents. And so this is a way that we kind of worked with them to kind of think about advocating for themselves for something that they weren't feeling like they were getting in their contexts. And then again, we talked about diverse attachment, discipline, conflict, and communication styles. And in this case, acknowledging that there is so much heterogeneity in the cultural background that our parents came, that we don't really talk about there being any right way to do things, but instead we have them and give them opportunities for them to identify what it is that they want for themselves. And we provide them skills to get that, and communication prompts for them to discuss what it is that they would want in their co-parenting or parenting goals. So this is just a framework of how we structured our lessons. So lesson 1 is introducing the concept of team parenting. Lessons 2 to 3 is really aligning and highlighting the value of self-care and relationship care. Lessons 4 through 7 are really providing skills like the ones that Mark had mentioned, communication, problem solving, and so on. And then lessons 8 through 10 are really highlighting some of those more complex situations. All right, so I'll just run through, we piloted this intervention, but just to kind of highlight, in the interest of time, some of the outcomes. After piloting, we actually ran an RCT trial of our curriculum, which we called the Strong Team Parenting Foundations trial, and we did a cluster randomization across 8 different schools. And what we found at post-test is that compared to those who didn't receive our curriculum, our participants, overall, all of our participants who received the intervention reported an increase in communication frequency and a decrease in conflict frequency. So that was a good thing. But where we saw the best impacts, or the most strong impacts, were for those participants who were not in a relationship with the other parent when they participated in our program. So they would be kind of our higher risk group. And for them, what we found is, again, participating in our program was related to more communication, or an increase in communication with the co-parent at post-test, a decrease in co-parenting conflict at post-test, and a decrease in unhealthy conflict resolution style at post-test. And those were kind of our short-term outcomes, but our longer-term outcomes, which we saw 3 months later, is that via these mechanisms of increased frequency, lower conflict frequency, and lower unhealthy conflict style, we saw that those who participated in our program and who were not in a relationship with the other parent also reported decreases in depressive symptoms, decreases in parenting stress, and increases in parenting satisfaction. So right now we're still kind of, assessing these shorter term outcomes, but it's showing that it is a promising program for our teens. The last thing I'll say is that nowadays we're also thinking about moving upstream and understanding the role that different contexts might play, both in the engagement of the program and in the impacts of the program. And I'll just share some very preliminary findings when looking at things like the context in which the students are engaging in, and just really looking at program engagement. What we're finding when we actually start to think about different elements of the context that they're residing in, one of the things that's come out after considering rurality, issues of like ethnic racial composition of the school and so on, that specifically experiencing teen parent stigma in the school by school staff significantly reduces the odds of our students completing our program. So it's related to program retention. Program alignment, like us having content that is relevant to them, as well as having discussions and activities and having very youth-focused programming, increases the odds of them engaging in our program and staying in our program. And then when looking at internal cultural strengths and tools that they might have, we see that for youth who have a positive ethnic racial identity, is significantly linked to an increase in the odds of them completing our program. So these are just some ways that I think for us, it's highlighting the importance of ensuring that we have programs that align with the experiences that our youth are having, and the importance of having youth-focused programming or participatory approaches to programming. It highlights the importance of leveraging internal cultural strengths, and also the need for us to engage in more advocacy at the school level to kind of highlight, the impact of stigma and how that might relate to program engagement and school engagement overall. So kind of just to summarize, I wanted to share a little bit about our working model, how social determinants of health via structural, bureaucratic, hegemonic, and interrelational mechanisms create social systems that promote or inhibit family and individual health. I wanted to share some recommendations, as specifically in the context of thinking about awareness, adjustment, alignment, and assistance and advocacy. And lastly, hopefully you were able to see one way in which our program is engaging in integrating these ideas through our cultural adaptation model and through the inclusion of measurements that are allowing us to identify future targets for advocacy. So with that, I'll stop, and thank you for all of the help I've received from all my team, and thank you all for your time.
Thank you both so much. I find this content to be so incredibly compelling. And for those of you who are still here, please feel free to pop a question in the chat. We have about a minute left, and I'll be monitoring that. I just am fascinated by this idea of co-parenting being this anchor for new parents, experienced parents, as they traverse the life course with all the dynamic changes that can come. This idea of co-parenting being this real anchor around which parents can invest and remain energized and focused, and have a shared identity. And just this work is so compelling, and this process of cultural adaptation and how brilliant that is, and going to the intended end users and saying, hey, what might need to change here for it to be a good fit to you? Is this in general feel like a good fit to you? And getting that assessment in at the outset. I'm incredibly compelling. I might be connecting with both of you by email just to thank you again and maybe ask a couple additional questions. But I'm cognizant of time. We're here at 3:30. You're getting some positive feedback here in the chat, and other folks agreeing with those comments. So thank you both again. So glad this was recorded, so it can be disseminated more widely. Want to thank all of you who are able to attend. Please keep your eyes out for ongoing listserv emails that will be notifying you of future webinars, and we hope to continue crossing paths. Thank you all very much.
Thank you, Todd. Thank you for coordinating.
Oh, my pleasure. I loved this presentation. So
sorry we didn't get to leave